بسم الله الرحمن الرحيم. أبنائي طلبة سنة 5، أهلا وسهلا فيكم. كل سنة وأنتم طيبين، وربنا يحفظكم من كورونا ومن غيرها، وديروا بالكم على دراستكم، مستقبلكم أهم حاجة، وبي سيف، تيك كير لو سمحتوا. موضوعنا في اليورولوجي، يمكن اليورولوجي من أخف المواضيع وأكثرها هضامة الحقيقة في الكلينيكال الكورس اللي هتاخدوه. موضوع بسيط لكن موضوع fairly common، سواء في الميل سواء في الفيميل سواء في التشيلدرن سواء في الكبار سواء whatever the age، يعني interesting الحقيقة يعني. ودائما في أسئلة كتيرة انتوا بتنسألوها حتى كمان كطلبة. احنا طريقتنا في الكورس هذا اللي هناخده تبع اليورولوجي لكم تحديدا لسنة 5، هيكون منهجنا هو المنهج الموجود في كتب الجراحة اللي معاكم، الجراحة المقررة اللي عليكم، الكتب المتعارف عليها عندكم. وتحديدا لو تكلمنا على كتاب بيلي اند لاف شورت تكست بوك اوف سيرجري، تتكلم على يعني whatever كتاب معاكم، I advise انكم تقروا الموضوع اليورولوجي منه، إضافة إلى بعض المواضيع اللي ممكن تلجأوا لها من خلال المحاضرات تبعتنا، من خلال الويب سايتس المتخصص، من خلال ريسورسز، قد تكون بعض الليكتشر، قد تكون بعض الصور، قد تكون بعض الفيديوز. وهذا اللي بأنصح فيه، ونكون على تواصل في أي موضوع وفي أي وقت لو سمحتوا، ما حد يتردد إنه يكلمنا. إحنا طبعا موضوع اليورولوجي مشترك مع موضوع يعني كمحاضرة مع موضوع البيدياتريك سيرجري، نصكم كده ونصكم كده، اتس اوكي. لكن احنا اليوم هنتكلم على موضوع اليورولوجي بصورة منفصلة تماما، والعلامات تبعتها بتكون منفصلة تماما للي مسجلين في الكورس معنا، وهتكون الأمور بسيطة وسهلة زي زملاتكم في السنوات الماضية. لكن النصيحة إنكم تقروا المواضيع أول بأول وما تخلوهاش تتراكم عليكم، ونكون إحنا على تواصل. إحنا في الجدول اللي نزل لكم هو هتكون غالبا يوم الثلاثاء إن شاء الله بتصير التعليم الوجاهي، ونيجي نتقابل مع بعض، وهذا جيد إننا نتقابل. لكن برضو التعليم عن طريق الموديل is very good، ما عندناش مشكلة فيه وانتم ما عندكوش مشكلة فيه. وحيكون اعتقد هو في يوم الثلاثاء صباحا، وبناء عليه تقريبا خلال الاسبوع قبل يوم الثلاثاء حتنزل محاضرة اسبوعيا تقريبا، قد يكون 2. لكن الفكرة انه حيكون مش هننزلهم مرة واحدة، ولكن بالتدرج عشان انتوا تقدروا تتابعوا المواضيع بطريقة صحيحة. بسم الله الرحمن الرحيم. أبنائي طلبة سنة 5، السلام عليكم ورحمة الله. اليوم هنتكلم على موضوع في اليورينري تراكت، من المواضيع اللي الحقيقة fairly common at different age groups، من infants في children في adults في elderlies in the women في pregnant في elderly، وممكن يكون life threatening الحقيقة، يعني condition إذا ما تعالجتش كويس، لأنه sepsis is a common urinary tract sepsis is one of the not uncommon presentation of deadly cases في ال ICU وفي الورds تبعتنا. Urinary tract infections could be divided into two entities. Infections could affect the upper part of the urinary tract or the lower part. إذا قلنا ال upper part of the urinary tract يعني نقصد بذلك اللي هي the kidney، بما فيها الكالسيال system، بما فيها the cells of the kidney، بما فيها renal pelvis and the perinephric area or the lower part of the urinary tract. ويقصد هنا اللي هو urinary bladder بمعنى cystitis، بمعنى prostatitis، بمعنى urethritis. طبعا the ureter in between could be affected still with some infections. The upper urinary tract presentations تبعته clinical entities are like acute pyelonephritis, chronic pyelonephritis, interstitial pyelonephritis, renal abscess or perirenal abscess. طبعا في glomerulonephritis is another entity that affects cells of the kidney. Some of it is autoimmune, some of it is having some other pathologies. لكن those are the entities which we are going to discuss in our presentations today. There is an entity called complicated urinary tract, could be affecting the upper or the lower simple urinary tract infection. وهدول complicated urinary tract يعني هنتكلم عليها later on. It depends on the organisms اللي في common organisms like infection of urinary tract, لكن presentation by other organisms could be affected also. The incidence of urinary tract عشان نشوف مدى incidence of urinary tract infections, especially age-wise and gender-wise. So age-wise, urinary tract infections could be seen in all age groups, as we mentioned earlier. In the infants up to 6 months 2 في الألف تقريبا. Most commonly in the boys than in the girls في الانفants احنا بنتكلم and the younger age group. In older ages 10% of the men and 20% في female in the women are infected with urinary tract infection. Gender wise, I mean sex wise, women are at greater risk than the men. وهنا simply عشان اليوريثرا كلها 4 ل 5 سم زي ما كنا شرحنا في الاناتومي واحنا سنه رابعه or في الاناتومي كورسز اللي بناخدها بصراحه. انما the urethra in the male is a little bit longer وبالتالي a little bit less than the men. Prevalence 40 to 50% of women and 0.04 in the men. هذا الانسيدنس which is fairly prevalent في الwomen. 10% of women have recurrent UTIs in their lifetime. 10% of the women معناته high incidence الحقيقة يعني. It is more common in a pregnancy. ولما يكون في عندي UTI في pregnancy هذا الانسيدنس والpresentation والتوقيت treatment is very crucial and important to know. We shall come across this issue later on. As we mentioned here, the urinary tract infection, upper or lower, could be simple or be complicated. Infection could be not by the usual organisms like gram-negative bacilli or other organisms, but infection could be by Pseudomonas aeruginosa and Enterobacter and Serratia. Isolated especially in hospital-acquired infections and catheter-induced urinary tract infection, وهذا very common الحقيقة. يعني احنا بنقول the commonest cause of urethral stricture sometimes is urethritis في young men على to talk about it. لكن traumatic injury by urethral insertion is another cause for urethral stricture. Viruses could be causing UTIs like rubella, like mumps, like human immune deficiency virus, HIV, fungi, candidiasis, histoplasmosis, protozoal infections like Trichomonas vaginalis and Schistosomia hematobia. Yes, those are rare, but they might complicate an already existing simple urinary tract infection. Clinical presentation or manifestations of UTIs in general. If we are talking about the lower urinary tract, we are talking about in general now, we are talking about it. Discomfort in voiding, on passing urine, there is some sort of dysuria, there is an urgency, the patient cannot hold, he had or she had to pass urine. Frequency is reached, the frequency times of urination will be more and more. Cystitis, inflammation of the mucous membrane of the urinary bladder, there is dysuria, there is urgency, there is a frequency in urination, there is pelvic discomfort, lower abdominal pain, sometimes back pain, a little bit if affected some other pelvic organs, abdominal pain, there is pyuria, that's to say pus in the urine, hemorrhagic cystitis, blood in the urine, and the bloody mucosa of the urinary bladder, there is visibly blood in the urine, or and irritating voiding symptoms whenever passing the urine. There is this burning micturition or scalding pain on passing urine. Some other on voiding male on passing urine, I mean. Now let us come more specific to the clinical presentation according to the age. In the younger age group, the baby or the infant cannot complain, but could keep crying and discomfort and irritated, and this is manifested by failure to thrive, cannot grow up, the baby or the infant. There is fever. To the ignorant parents, they cannot pay too much attention for that. But there is a fever, there is an apathy, there is a diarrhea, there is sometimes toxemia secondary to this. In children, there is dysuria, there is urgency, there is frequency, hematuria, blood in the urine, occult or visible blood, acute abdominal pain sometimes, then vomiting is there when toxemia is there. In the elderly and the adults, if it is the lower urinary tract, there will be frequency and urgency, dysuria, hematuria. Upper urinary tract infection, there is fever. Whenever it's having systemic manifestations of urinary tract, this is an ominous sign. This is not good sign. Many of the inpatients, whether in the medical or surgical wards or urology wards, are having fever secondary urosepsis, sometimes we call that. There is rigors, this is septicemia, there is loin pain, both bilateral or unilateral, and symptoms of your lower urinary tract infection. In the elderly, mostly asymptomatic. The elderly, if not paid an attention as if common symptoms to him or her, and this is very serious to the elderly. Whenever there is something not clear in the elderly, we are to go and simply do urine analysis. Pay attention, examine the abdomen, examine the line. You will detect there is something in the kidneys, whether upper or lower urinary tract infection. What are the causes of urinary tract infection? Mostly three big entities of urinary tract infection. Of course, it could be hematogenous, it could be ascending along the ureters through the lymphatics, or ascending the peri-ureteral lymphatics. So the causes number one is ascending along the ureter from the lower urinary tract. There is an infection in the bladder or the urethra and just sending the organism to the kidney. Commonest cause in obstructed type of obstructive uropathy, like an obstructed neck of the bladder by a prostate, by a stone, by whatever. So the organism will jump up to the kidney, or in cases of vesico-ureteric reflux from below up. Okay. Number two is the ascending and the peri-ureteral lymphatics from the cervix or the prostate. This is very important. That's to say, lymphatic spread of infection. And then hematogenous from even a distant focus, like repeated tonsillitis, septic focus somewhere in the body, skin boils or carbuncles, or tuberculous lymph nodes, like the neck or chest or abdomen. Concerning the upper urinary tract infections, as we mentioned, common organisms, or even the lower urinary tract, the commonest is the E. coli, Escherichia coli, plus the other gram-negative organisms. Of course, there must be good correlation between the perennial organisms, which are potentially harboring those organisms, like the stool in the area, and the stool is mostly having gram-negative bacilli. If not cleaning well, if the dresses are very not clean enough, so the organisms are there. Number two, Streptococcus faecalis, and this is given an acidic urine. Proteus and the staphylococcal infection, and this is have a specific function. That's to say, it could split urea to ammoniacal odor or to ammonia substances. Hence, the urine is alkaline mostly. In a Proteus infection, mostly the urine will be alkaline, and also in the staphylococcal, mostly it is alkaline like that. And the cause for that is the ability of the Proteus or staphylococcal to split urea to ammonia, which cause alkalinity of the urine. This is very important when trying to look and read the analysis of the interpret the analysis of the urine and the possible organisms before the culture, and on that basis you could start a treatment, especially if your patient is toxic and you would like to give some sort of empirical antibiotic. Let us come to the clinical entities and syndromes of the urinary tract infection. Acute pyelonephritis. Pyelonephritis, if that's to say infection in the kidney itself, in the renal pelvis, and the nephritis in the renal papillae of the kidney. The incidence here it's more in the female, in childhood, in puberty, and it is sometimes called honeymoon pyelonephritis. Some people are calling that honeymoon cystitis. It is a misnomer really, but it is mostly honeymoon pyelonephritis. As you will see later on, the patient during this period might have very high fever. So it is correctly named as honeymoon pyelonephritis, not simply cystitis. During a pregnancy, it is more to 6 times more on the right side, and the reason for that is there is some inclination. The extroverted uterus will cause some sort of a relative or physiological obstruction to the lower ureter, so there is a relative stasis and organisms could flourish more in a relatively static urine. So organism infection of the kidney itself will happen more during pregnancy. This is very important. And after menopause. You know why more in the female? As we said, the very short urethra, very short distance of the organism to go ascending through the urethra to the bladder, to the ureter, to the kidney, causing acute pyelonephritis. It is more common on the right side, as we mentioned, but infrequent. It could be bilateral of cause. In vesicular reflux or a bladder neck obstruction, or in distal obstruction of the urinary tract. The root is mostly the root of infection, hematogenous secondary to the distant focus, or local one and ascending infection, as we mentioned earlier. And this is the picture of the kidney. Look at the pus in the kidney. It is terrible, really, if it is, like the pus is harboring, this is the pus, and this is the kidney being damaged, being shrunken, and the terrible situation is there. Clinically, in the early stages, this is very important, really, the clinical courses of such a case of acute pyelonephritis. There is a prodroma before the full-blown picture of pyelonephritis. There is headache, there is lassitude, nausea. The onset is sudden with rigors. There is vomiting. The pain in the loin, the pain in the loin and the renal pain is always dull, aching pain. It is not the radiating one. So, and the pain in the kidney is mostly could be referred to the hypochondrium, whether left or right, according to the site. I may radiate to the groin. It could radiate, but it might not radiate. So think of it. And there is a fever, sudden onset of fever, 38.8 to 39.5 to 40 something. And this is a remittent fever, and the frequency of micturition. The fever is very important and pathognomonic. If it is on the right side of the abdomen, differential diagnosis is acute appendicitis. Appendicitis will not the picture all of a sudden of 40 or 39 all of a sudden. But in this acute pyelonephritis, according to the type of your patient, as we are always mentioning, so a pregnant lady or a young child having sudden distress of fever, tenderloin, think of pyelonephritis more than anything else. There is a scalding pain still. In the severe cases, there is rigors. The patient will become toxemic if not having treatment. So rigors constitute a temperature about 40 to 40 something, tachycardia, vomiting, sweating, thrill. The patient will be tachycardia and dehydration later on. Urine is scanty and concentrated. By examination, there is tenderloin. Murphy sign is positive. We are called Murphy point. There is positive in there, in the loin. Loin Murphy sign. And hypochondrium with rigidity. If we are coming to the urine analysis, look at the urine analysis. In the early cases of acute pyelonephritis, the urine is clear, but the patient is having fever and some other constitutional symptoms. So take care. If the urine is clear and the patient is febrile, you cannot say there is no renal touch in this patient. So it is clear. Classically, natural history of acute pyelonephritis, in the early cases, urine analysis is clear. Even microscopically, in severe cases, there will be scanty urine, few pus, cells and bacteria, and in the late cases, we are going to jeopardy of the kidney. There is a cloudy urine and many pus cells with the bacteria in there. anti-protein. Differential diagnosis pneumonia, very important, right basal pneumonia mainly, or basal pneumonia on both lungs. But this is very important differential diagnosis. Acute appendicitis, as I mentioned earlier, acute cholecystitis, and we know how to differentiate, to do proper blood studies, to do an ultrasound, to know where is the picture, and always put high index of suspicion, the type of your patient. If a child, a newly married lady, an elderly with the previous manifestations, think of acute pyelonephritis, please. Clinical picture, you might do an ultrasound, an intravenous urography, even an isotope renogram and a chest x-ray are mandatory together with a good ultrasound. Treatment of acute pyelonephritis, there is a rule of thumb in here. Early, correct, and prolonged therapy. Don't say 2 or 3 or just a course, 5 days. No, the course continued up to a month or more than that. So early, correct, and prolonged therapy and follow up urine culture and sensitivity, plus full investigations, including the urine, the blood, ultrasound, IBU if needed, so as to make sure of the diagnosis. In addition to the type of your patient, clinically you are thinking of acute pyelonephritis. So the treatment principles or main clues for that, number one is the complete rest, bed rest, urine, midstream, always the urine sample you are to mention to the laboratory technicians what specimens to collect from the patient, either initial or terminal or midstream or a 24-hour or 12 hours urine analysis. So midstream عشان ما تكونش contaminated by anything. Midstream urine analysis stream, not the midstream, and even semen analysis if female, we are to do that. Analysis and culture sensitivity, alkalinize the urine. If your patient is having some other organism which is not causing the alkalinity of the urine, plus potassium citrate, so as to enhance if any possibility for urolithiasis even in there. Analgesics and antispasmodics are a must. Bring the temperature of your patient down. High fluid intake, at least 3 liters a day your patient will need, and consider what has been lost from the patient. Antibiotics, start with the broad spectrum antibiotics or the possibility of antibiotics according to the culture, of course according to the culture, but before the culture it will take at least 2 to 3 days. So you are to start by a broad antibiotic which could be covering the organism. Earlier we said that gram-negative bacilli could be there if your urine is acidic. So start with something affecting the gram-negative bacilli, as simple as that, till the culture is the result of culture and sensitivity is coming, and on that basis either to continue with the same antibiotic or to change it. Send urine again after weeks to make sure your patient is responding. Continue with another antibiotic for 2 to 3 weeks. You see, your treatment will be at least 3 to 4 weeks. Very important. وهنا غلطة بعض الفيزيشنز إنه بتدي المريض كورس بيستجيب ببطل المريض يكمل. No, you are to repeat the culture. You are to continue up to 3 weeks. Do another culture and sensitivity عشان الحالة ما تصيرش chronic ويحصل damage للكدني till the urine is clear on 3 occasions. recommended antibiotics لو كانت الكلية good functioning kidney ممكن نديجين طبانسين، كاربينيسيلين، اميكاسين، سيبروفلوكساسين, empirical ones, but ideally antibiotics according to culture and sensitivity. Sulfamethoxazole, Ceptrin, like Ceptrin containing drugs, nitrofurantoin, or some other proper antibiotics. Full work up of the urinary tract. Make sure there is no stasis in the urine in any part of the urinary tract, except the annular stasis will enhance not only the infection but also the urolithiasis, that's to say stone formation. This will complicate the infection more and more. If our patient is not responding, our treated and or under-treated this acute pyelonephritis, he might go to the to the clinical entity of a chronic pyelonephritis, chronic status of pyelonephritis. So it's known that the chronic pyelonephritis is one of the common causes of renal failure. It may be primary or secondary to other renal disease. The pathology will in the kidney. ايش الباثولوجي اللي بيصير في الكدني؟ بيحصل scarring في الكدني, microscopic and interstitial scarring in the renal parenchyma, damaging the functioning unit of the kidney, the nephrons. And this will be started in the tubules and later in the glomeruli. In the tubules starting, then in the glomeruli. Tubular atrophy and dilatation up to cystic formation of any chronic pyelonephritis. Clinically, the unusual picture, imagine a patient with a chronic pyelonephritis might go in renal failure asymptomatically. That's to say the patient might not complain of anything more or less, I mean. Of course, there will be some, but the patient will be neglecting enough to go asymptomatic, up to renal failure. This is very ominous and very troublesome. Common presentations are lumbar pain, dull in character, 60% of cases the renal pain وبالتالي بيكون dull aching pain. Frequency and dysuria will be there. Hypertension, chronic pyelonephritis بيكون عندهم hypertension mostly, نصهم أو 40% may be malignant hypertension, not responding في 20% منهم. There are some other constitutional symptoms on and off, pyrexia more than 37.8. There will be anemic, which could be normochromic. This is a chronic state of sepsis. So in investigations to do for chronic pyelonephritis, of course, after the workup and seeing what is the function of the kidney, mainly we are asking about the creatinine and urea and some other indicators. For urine analysis, there is a proteinuria less than 3 grams a day. CAS will be infrequent. CAS is very ominous, especially لما نتكلم على hyaline CAS or protein CAS. هدول من الساينز اللي بتعمل it will equal renal damage or going or impending renal failure in this patient. White blood cells, pyuria will be there, numerous white blood cells in the urine by fresh amount of 3 specimens, أكثر من 200,000. Urine culture and sensitivity, mostly we shall culture E. coli and Streptococcus faecalis, Proteus or Pseudomonas. It depends according to the organisms just we mentioned earlier. Treatment of chronic pyelonephritis, as we say, there are principles for chronic pyelonephritis to treat. Number 1, treat any predisposing factors like stone or infection. As we mentioned, stone will cause a staph infection, had to be treated by the proper dose and for the proper duration, weeks or months or something like that, and the stone to treat. Repeat culture and sensitivity of the urine till the urine is clear. Nephrectomy sometimes if there's a bag of pus or septic focus in there, so we could be obliged to do nephrectomy or partial nephrectomy according to the site of the kidney being affected. I mean upper pole or lower pole nephrectomy. Repeat kidney function test to make sure you are progressing with your patient in treatment. Proper and other related investigations in time and according to the insult اللي حاصل عندنا في الكدني. Now another very important issue, very important, this pyelonephrosis. Pyelonephrosis يعني pus in the kidney itself, and the causes are infection of a hydronephrosis. You know hydronephrosis and the causes for that in obstructive uropathy. That bag of or that cyst in the kidney or that part of the kidney will be like a bag of pus in there. Following an acute pyelonephritis, so complicating acute pyelonephritis, مش chronic, صار عندي pyelonephrosis again, or calculus pyelonephrosis, the emergency, this is an emergency calculus pyelonephrosis because there is an obstructed kidney or obstructed part of a kidney, there is a pus and there could be a stone or a neoplasm obstructing the passage of the secreted urine in the kidney to urinary tract, and this definitely will cause septicemia in this patient. So pyelonephrosis, if you came to this diagnosis, it's an emergency mostly. Pathology, grossly the kidney is multilocular and filled with pus or purulent urine with varying thickness of its wall. Clinically, There are triad to think of it. Triad: anemia, fever, and loin swelling. Anemia, fever, loin swelling. Anemia, fever, loin swelling. Those are pathognomonic to pyelonephrosis till proved otherwise. Please, anemia, fever, loin swelling. Of course, not all of them could be found. The patient might come with fever alone, not anemic, or anemic without a fever properly, or there could be no swelling. So not all the three are there, but if you have them in there, so it is mostly pathognomonic, but mostly the patient will have those three things. This is the, simply obstructed pyelonephrosis. Some stone formation, some thick pus in there, damage to the kidney tissues, terrible situation to the kidney. So the investigations in pyelonephrosis are simply plain X-ray, so how much is the nephrogram of the kidney could be shown in there. Stones are in there. Renal ultrasound will show you the thickness of the cortex of the kidney with the medulla in there. Urine analysis is a must, of course. Urine culture and sensitivity, cystoscopy to see if there is any other pathology, if you didn't come across something to solve or to give some answer to something. Kidney function tests, repetition of the kidney function tests are important to repeat till they are coming normal, or to see the progress at least. The treatment in pyelonephrosis, there is a rule of thumb again: an infected obstructed kidney is an emergency, as we mentioned. So infected obstructed kidney is an emergency. If you think of it, please admit your patient to the hospital on spot. Antibiotics, broad spectrum antibiotics to start with, but this is very important. But you are to make sure that there is a good drainage of the kidney. So a double J catheter, and by double J we meant there is a catheter, an end of it will be in the bladder, the other end in the renal pelvis. A catheter long about 30 centimeters, 26 to 25, it depends on your patient. Double J catheter inserted through a cystoscope, or if you cannot do a cystoscope, percutaneously under an ultrasound or CT scan, or even by surgery, by opens nephrostomy, we are calling that. So removal of any obstructed element like a stone, later nephrostomy to the damaged kidney. Sometimes you might need to do nephrectomy if you cannot salvage the kidney, being an infected, being a septic focus, and it is not functioning kidney mostly. But we are not rushing to nephrectomy always concerning the kidney. Another important topic among the renal infections is the carbuncle of the kidney. We know the carbuncle in the skin. You know the carbuncle? We are calling it infective gangrene of the skin. This is very important. And the carbuncle is carbuncle of abdominal wall, carbuncle of the nape of the neck. وهذول بيكونوا multiple follicle, some gangrenous tissues, unhealthy tissues, massive tissues, unhealthy. So more or less a process like this, gangrenous part or unhealthy parts or a damaged part of the kidney tissue caused by infection, we are calling it carbuncle of the kidney. And from now to tell you, just put in mind, we are not saying carbuncle of the kidney except if you are ruling out a neoplasm, a malignant neoplasm even to the kidney. This is very important. That's why we had to know this entity of pathology in the kidney. Pathologically, we can say that the source of infection for the carbuncle of the kidney is either hematogenous from a cutaneous lesion or an abscess, say an abscess in the breast, could be triggered by a trauma, and there will be hematogenous. The organism will go to the kidney and settle in there, causing the damage in the kidney. Organisms could be Staphylococcus aureus, gram-negative bacilli, like an infected hematoma, morbidly, the kidney having forum of necrotic tissue, and by that is meant, we are to rule out some other pathology in the kidney. This is very important to rule out, very important differential diagnosis to the kidney. Now, Clinically, the patient will have vague, tender swelling in the loin. There could be no swelling, but vague and pain in the loin, dull aching pain. There is pyrexia. There is leukocytosis by investigations. Urine analysis, again, like this, that acute pyelonephritis, if you remember. The urine could be clear if it is not communicating to the collecting system. Later on, Staphylococcus aureus could be cultured in there. IVU, there is a mass deforming the calyceal system, the pelvic calyceal system, and it is a differential diagnosis for a hypernephroma or adenocarcinoma. Treatment, simply proper antibiotics if you came to the diagnosis, or nephrectomy, removing the necrotic tissues and the drainage of the area with a big bore, a tube drainage outside. Nephrectomy is indicated only if the kidney is severely damaged and no more effective and no hope to treat it by antibiotics and just simple drainage. Perinephric abscess, very important entity for this in surgery in general, I can say, really. Perinephric abscess, that's to say an abscess around the kidney. And the source of infection in the perinephric abscess, number one, is the hematogenous abscess from a distant focus through the blood. The organism will there and will invade the tissues, or blood going to the kidney is being affected, and this is, the perinephric tissues, whether fat or the capsules of the kidney, will harbor this infection via periurethral lymphatics, extension from an appendicular abscess or a cortical abscess, infection from perirenal hematoma, or perforation of the renal capsule, and there is an infection in the depth and the substance of the kidney itself during the course of pyonephrosis or renal carbuncle itself. It might rupture or perforate outside the kidney. TB, perinephric abscess, this is very important entity. Always looking at the type of your patient and where your patient is living. Even in some areas like in India, like in South Africa, where TB could be common in there, you are to think of it. Tuberculosis, perinephric abscess. Even sometimes we are treating some patients empirically if their area is indicating a tuberculosis in that area, and it could be secondary to a Pott's disease, TB of the spine. TB of the spine, which starts in the body and there is the tuberculosis process in there. So perinephric abscess, it could be tuberculosis also. And if we know the cause, it is simple. If you know the cause, just anti-tuberculosis drugs. If you know the organism, just drainage the abscess and give good antibiotics, good anti-tuberculosis, and that's all. But think of it, please. Clinical course in perinephric abscess, classically there is fever, and it could be high hectic fever. Sometimes you are giving everything, the patient is not responding. So we are to think sometimes of tuberculosis, even to give anti-tuberculosis drugs even. There is fullness in the loin, there is tenderness in the loin. There is rigidity in the loin. Very important to examine the loin and the back of the patient while being sitting or supine. But signs are variable. Not all those signs are found in the patient, but think of it. CT scan could diagnose that in a good way, okay? And the pathology could be in the upper or lower part, or taking most of the kidney tissue. So the labs in those patients, the white blood cell could be in the range of 20,000, more than that even, a little bit less. Urine, no pus or bacteria as a rule. ما communication between it and the pelvic calyceal system, mostly I mean. وبالتالي this perinephric abscess without urine being affected, I mean sample of urine taken out. A KUB, no psoas shadow, and this is very important if you are talking about psoas shadow. You remember the psoas shadow, like a triangular area around the vertebra, right and left. No shadow on the diseased area. There is a scoliosis, lateral curvature of the colon to the right or to the left, according to the pathology, diaphragm elevated and immobile. Treatment of perinephric abscess is a drainage. You see, only drainage. And give the proper treatment like antibiotics or antituberculosis. Open through a lumbar incision or under a CT scan or ultrasound, but it had to be under cover of good antibiotics, proper antibiotics, before doing manipulation so as not to disseminate the infection. Septicemia and microabscess in the kidney causing, this is very serious issue. If we are talking about, some septicemia or some damage of the kidney secondary to pyelonephric abscess, secondary to pyelonephrosis, and this is the septicemia of the kidney of a septic patient. Thank you very much. Bye-bye.